from where we are streaming. Good evening, students. Good evening. Hello, hello, hello. Welcome, students. Welcome, all of you. Can all of you hear me? Can all of you see me? Hello, hello, hello. Welcome, students. Yes, I think we are live. From where we are streaming, there might be slight lag. And can you just somebody in the chat box so that I know the chat box is also functioning very well? Welcome, all of you. Very important session for this upcoming FMGE examination. Okay. And all of you, we are going to have very important clinical case MCQs. Also, these are the Yes, thank you. Okay, so these are the top 5 topics, and with topics we are going to discuss, of course, the MCQs, and I'll also tell you these are extremely important topics which are surely going to be repeated in each and every examination. Okay, yes, thank you. Okay, so before we proceed further, just a couple of so it's going to be, let it make it like an interactive session. Let all of you answer. Right, wrong does not matter. We are all here to learn from our mistakes. So if you make it wrong, no problem at all. And before we proceed, request all of you to quickly follow me on Insta and also subscribe to my YouTube channel. Thank you, Dr. Bhanu Prakash. We are on Dr. Bhanu Prakash channel, but you also please subscribe to my YouTube channel where lots of important videos are there, and feel free to get in touch with me on phone and WhatsApp on this number so that I can guide you. I'm personally guiding all the students how to study, how to prepare. And moving on to the very important point, all of you, this is a very important video I have put on my OGGuru YouTube channel, how to prepare for the FMGE in 80 days. The link of this video is in the YouTube description. You will find this video on my YouTube page. It is very important. I have given a 80-day strategy. I have said what you should study, which subjects are important, which subjects are less important, and also I have given a grand test plan and how to improve the grand test score also I have mentioned. So please check out this video. Students are finding it really helpful. There's a complete schedule, which subjects are important, which subjects are less important, which you can leave in choice, and which you can, we have to focus more. Everything is discussed in that video. So please go and check this video also. Okay, and do not forget to download my OGGuru app on Android as well as on iOS. And for iOS, you need to put the ORG code YYMSTV. And just an important point, this week I'll be celebrating my birthday, so a gift from my side for all the OGGuru subscriptions once in a year. OG gift is the code. More about this later on, where you can master the entire OBGY in just 40 hours. Okay, more about this will come later on, where you will become experts of OBGY and your score will jump up. If with current knowledge you are getting 10, 11, 12 MCQs correct, then you are going to get, after my videos, 28, 29, 30 MCQs correct. That's a very important jump of 15 to 20 marks. So many students get stuck up at the score of 135, 140, and then they take this and then they clear. Okay, so moving on. Yes, I want it to be an interactive session. All of you, please tell me the first MCQ. First, tell me the diagnosis. Can anybody tell me what is the diagnosis? We have a longish case. This is a newer pattern in FMG where we are getting clinical case scenarios. So, primi gravida admitted with bleeding in the bleeding PV, pain in abdomen since 2 hours, pulse given to you, BP given to you, fetal heart given to you, 3 centimeter dilated, blood stained, liquor is observed. What is the management? So first I want all of you to tell me the diagnosis. Anybody with the diagnosis? I want all of you for Yes, anybody with a diagnosis? I cannot yes. What is our diagnosis? Anybody? What is our diagnosis? Yes, okay. Shruti Raj, okay. Placental abruption, okay. Placenta previa, no SRV. Okay, so this is the first important topic. As I said, I'm going to tell you the topic. The first important topic for the day is your antepartum hemorrhage, and what is going to be common. Okay, all of you, yes, very good, Anamika Arna. Okay, so what is going to be important is that in APH, the patient will come to us with bleeding in the third trimester. Now, how will I differentiate in the bleeding? Remember, my dear students, when it's bleeding in third trimester, either it's going to be abruption or it is going to be placenta previa. Now, what is the main part? Can anybody tell me how do I differentiate? So please keep in mind that, yeah, nursing students also, it can benefit you also. Chandan Rana, you can pay attention. So abruption is always painful bleeding and placenta previa is painless bleeding. Yes, and very important point. Can anybody tell me what is the etiology for abruption? For abruption, the etiology is your preeclampsia or hypertension. Very likely that a patient will have high preeclampsia and hypertension will lead to abruption. So here the patient's blood pressure will be high and preeclampsia, hypertension will be present. Yeah, trauma is rare, beta, and here the BP would generally be normal. Yes, after a lot of bleeding, the patient will go in shock and then the bleeding will decrease. That is okay. But here there is no connection to preeclampsia and hypertension. Is this understood to all of you? Okay, so now please pay attention, and most importantly, can you tell me when I palpate the uterus, how is going to be the uterus when I palpate the uterus? How is the uterus going to be? Anybody? How is the uterus going to be when I palpate the uterus? Okay, so when we palpate the uterus, here the uterine tone is going to be increased. So if anywhere in the question paper you get tonically contracted uterus, blindly mark abruption. So uterus is going to be, tone is going to be increased and it's going to be a tonically contracted uterus, and here it is, yes, tony hard donor, and here the uterus is going to be relaxed. Here the uterus is going to be relaxed. Is this understood to all of you? So this is very important 5-star slide, that bleeding in third trimester. Now tell me, yes, very good. Now tell me all of you, what is our diagnosis? So here we have got pain in abdomen. I'm telling you how to interpret the question. Pain in abdomen hai. BP is also very high, 150, 100, and ARM, very important, blood stained liquor, you can blindly mark abruption. Is this understood to you all, my dear student? Blood stained liquor, it is abruption. So now anybody, what is the next line of management? Chalo, A, B, C, D. I want all of you to answer. Anybody? A, B, C, D. Chalo, A, B, C, D. A, B, chalo, all of you, right, wrong, does not matter. Okay, and can you tell me one more important point? One more important point. So remember this, keep in mind, my dear student, abruptio placentae, never wait and watch and never give tocolysis. Okay, abruption is always progressive. It will always increase. So in abruption, you never wait and watch. Keep this point in mind. Okay, never wait and watch, otherwise the bleeding will keep on increasing. And very good, please all of you look over here. What is the fetal heart rate? 100. What is it? Is it less or no? Yes, the normal fetal heart rate 110 to 170. So the fetal heart rate is on the lower side. This is indicative of fetal distress. Is this understood to all of you? So if in fetal distress you wait and watch, you have to go to jail. Is it clear? Jail matlab you have to go to jail. Why? That means punishment, because if you wait and watch, the baby will die. So never give tocolysis, abruption will worsen. Never wait and watch in abruption, because there is fetal distress, and we are only 3 centimeter dilated. Forceps delivery is also not possible, and no, okay, no, see, okay, and oxytocin augmentation is not possible at 3 centimeter, because she's only 3 centimeters. There's a lot of long time to delivery. Oxytocin augmentation we can do if the fetal heart rate is normal and delivery is likely to happen, like suppose she's 8-9 centimeter. So here a primi gravida who is only 3 centimeter has got lot of time, 5, 6, 7, 8 hours before she will not deliver. So I have to do the delivery because it is fetal distress. So what is in fetal distress? You need to do the delivery ASAP, and therefore the answer is cesarean section. Yes, all those who have got it correct, option A is correct, and cesarean section is the answer. So please don't wait and watch, and you'll come to know the variation in the question also when I teach you the next question also. Is this understood to all of you? So blood stained liquor, keep in mind, because when you do ARM, all the liquor will come out. Okay, in in placenta previa, liquor will not come out. Okay, please understand this very important difference also. Whenever there is placenta previa, all of you please look on the board. So this is the uterus and this is the placenta. This is the placenta, that is placenta previa. So in placenta previa, all the bleeding is revealed, and the baby is up. Okay, so the liquor, all the liquor is around the baby, so that liquor cannot come out. Is it understood to all of you? So placenta previa, first of all, we are not supposed to do a ARN, we are not supposed to do a PV, but it is not possible for the liquor to come out also. Keep that in mind. So therefore, blood stained liquor is also a very important clue, and blood stained liquor also points towards abruption. Is this understood to all of you? Moving on to the next very important MCQ, all of you please tell me, what is the diagnosis over here? What is the diagnosis? 34 weeks pregnant lady admitted in view of first episode of painless bleeding, episodic bleeding, and BP is okay, pulse is uterus, hemoglobin okay, uterus relaxed, head floating, fetal hearts given to you. What is the next line of management? Anybody? I want all of you with the diagnosis first. What is the diagnosis? What's the diagnosis over here? Okay, what's the diagnosis? Okay, wait and watch, placenta, holy treasure. Okay, so diagnosis, yes. So now please understand this. What is it important, sir? Painless bleeding, BP normal and uterus relaxed. So this is our placenta previa. Both these are extremely important topic for the upcoming FMG examination. Very good. This is placenta previa. Excellent. And keep in mind okay, as I told you, uterus is relaxed. And why is the head floating? See this baby, this placenta prevents the head from coming down or entering the pelvis, and therefore generally in placenta previa the head is going to be floating or it is unengaged. Okay, unengaged head as mentioned in the question paper. Now the mistake student make is, please understand this, बेबी प्लासेंटा फाड़ के बाहर नहीं आएगा. Yes, baby cannot perforate through the placenta and come out. Fata placenta, nikla hero or heroine. That's not possible. So remember this, my dear student, that placenta previa, we will always have to go and do a cesarean section only. The delivery in placenta previa, hold on, that's not the answer, okay? The delivery is always by LSCS in a patient of placenta previa. So please understand this, in placenta previa, you are never supposed to induce labor. Anybody? What will happen if I induce labor in placenta previa? No, Zinat Fatima. If you induce labor, jail. You'll have to go to jail. बात समझ में आ रहा है? Why? Because please pay attention that, my dear student, in placenta previa, if you do induction of labor, the bleeding is going to increase. It's going to worsen the bleeding. And similarly, forceps is also not possible. How will I apply the forceps? Placenta is covering it. Yes or no? Clap if you have learned something new. Placenta is covering the cervical os. How will I apply a forceps? Is this clear? So induction of labor नहीं करना है. Why नहीं करना है? Because if you induce labor, uterus will contract further. The bleeding is going to increase. You will be put to jail. Is this understood to all of you? So placenta previa, the delivery is by LSCS. But when? Now please understand this. What is the important point in this question paper? She is only 34 weeks. She is only 34 weeks. Is it clear to all of you? Importance of every word. She is only 34 weeks. And is the mother stable? Yes, sir, the mother is stable because PP normal, hemoglobin normal, and fetal heart rate is also normal. That means there is no fetal distress, and therefore I will wait and watch over here. Is this understood to all of you? Wait and watch is the answer. And what do I do in wait and watch, all of you? Sir, when I wait and watch in placenta previa, what it is called as, all of you? McAfee and Johnson regime. McAfee and Johnson regime or regimen, where I can wait and watch in placenta previa. Now, can anybody tell me why I want to wait and watch? What is the only reason why I want to wait and watch? what is the only reason why I wait and watch in placenta previa? What is the only reason why I wait and watch in placenta? Yes, excellent, excellent. The wait and watch, holy treasure, Zenith, very good. The wait and watch is for the fetal lung maturity. And therefore, please understand this. When I want to wait and watch, three conditions should be satisfied. What do I do in wait and watch? I admit the patient, give her steroids, give her tocolytics. So I can give tocolytics and then don't go to the room and sleep. Closely observe the patient for any further bouts of bleeding. So when I want to wait and watch, all of you look on the board. Common sense, the mother should be stable. Yes or no? Common sense. If the mother is in shock, wait and watch for what? For the mother to die. So then don't wait. Okay. So if the mother is in shock, I will not wait and watch. So mother should be stable. Second, there should be no fetal distress. Is this understood to all of you? Okay, sir, then only I will wait and watch. There should be no fetal distress. And third most important point, pregnancy should be less than 36-37 weeks. Then only I will wait and watch. And the important point, all the three criteria should be satisfied. We should get 3 out of 3 score. Is this understood to all of you? So now if you look at this question paper, my dear student, we are only 34 weeks. Is the mother stable? Yes, sir. Mother is stable because hemoglobin okay, BP okay. So yes, mother and baby is also stable. There is no fetal distress and therefore wait and watch is the answer. Thoko tali, clap if you have learned. Is it clear to all of you? So I will wait and watch. But now if you get a variation in this question paper, if you get a variation in this question paper where I change only one digit, I change only one digit and instead of 34 weeks, I make the question as 37 weeks. Anybody, what is the answer now? Chalo, all of you. My question to all of you is that, sir, instead of 34 weeks, now my question paper is telling us 37 weeks. So now what are we supposed to do? Yes, very good. Sir, now, sir, there is no point waiting. And now the answer, if it is 37 weeks, it is cesarean section. Is this understood to all of you? So see, एक digit आपका answer change कर सकता है. So that's why my students don't mug up. Hashtag crystal clear concept. Yes, sir. That's why students tell me, sir, we read so many books, not able to grasp the concept. You will get the best concept. So 34 weeks hai, and therefore 34 weeks, I can wait and watch, and that is the answer. Is this understood to all of you? So placenta previa is the name of the topic or the name of the important topic, and yes, we can wait in placenta previa, and that is the answer, which is McAfee and Johnson, because we are 34 weeks. If the same patient is 37 weeks, then sir, we would like to go for LSCS. Or if it is fetal distress, then I don't wait. Mother is in shock also, then we don't wait. Beta, you don't, holy treasure, we don't require a classical, okay? Classical is not required, lower segment is good enough, okay? We don't have to do classical, okay, beta? So you can just do a LSCS only, lower segment is good enough, LSCS. You don't have to go, you don't have to put a classical cesarean, okay? Is it clear, teacher? So LSCS best at 37 weeks. So do not directly mark LSCS answer. See mother, see baby, and please never induction of labor. Induction of labor, never. Okay, never go for induction of labor. You'll have to go to jail. Okay, jail means you are killing, you are causing damage to the mother. Okay, so wait and watch. And as I said, if mother is in shock, then blood to the mother and direct LSCS. Fetal distress, direct LSCS. Pregnancy charges 37. If term, then we need to deliver. Yes, very good, Shruti Raja. Okay, if we are 37 weeks, then sir, there is no point waiting. You are sitting on the time bomb, diffuse the bomb before it explodes. So once you reach 37 weeks, very good, Shruti Raja, then let the mother be also stable, let the baby be also stable. If the mother is stable, if they give you the question paper, mother stable, fetal also stable, mother and fetus both stable. But if you reach 37 weeks, then also you will not wait, and then directly we will do LSCS only. Is this understood to all of you? So once the mother and baby are stable, there is no point of waiting further, and then we directly do LSCS. Okay, moving on to the next MCQ. Very, very important. Again, a short topic is surely going to come about this antenatal trisomy. So difficult. So tell me, primary gravida has come to us at 12 weeks of gestation. Dual marker test is done. Okay, now first of all, many students do not know this. How do I do a dual marker test? Okay, and it is the dual marker test report is showing positive or high risk for trisomy 21. What is the next best step? Anybody? Yeah, but Mohammed, PDF will be uploaded later on after the whole thing is over. You'll get the PDF of this also. Okay. Yes. Anybody? What do you do? Somebody saying MTP. Okay. Okay. What? Anybody? All of you. Okay. And quickly, please share this link of video with all your friends and tell them also, so more and more students can join live. Please share this video with all your friends and colleagues, and also subscribe to my YouTube channel and get in touch with me on phone and WhatsApp on this number for your further timetable and guidance. Now, please understand this quickly. Anybody? What is the dual marker test, and when is the dual marker test done? Anybody? And how is the dual marker test done? Can anybody tell me, how do I do a dual marker test? Anybody? Dual marker test, how is it done? Amniocentesis, CVS, how is the dual marker test done? And what is the component of dual marker test? All this. So say with one MCQ, no, only 18, no. With one MCQ, I'm teaching you 5 more MCQs. Okay. So point number 1, yes. Point number 1, dual marker test is a simple test done on maternal serum. Many students tell me amnio, CVS, no. Mother's blood is taken, maternal serum. It's a screening test, very good. And when do I do it? We do it towards the end of the first trimester, where somewhere between 11 to 13 weeks. It is done in the first trimester. Is this understood to all of you? And the components are HCG and PAP-A. PAPPA. Can anybody tell me what happens to the value? Okay, HCG, human chorionic gonadotropin. PAP-A क्या है? Pregnancy associated plasma protein A. Okay, so yes, very good. So dual marker is a blood test. Yes, it's a blood test, not on amnio, CVS. What happens? Very good. Sir, HCG is higher than normal and PAP-A is lesser than normal. Excellent, all of you. Excellent. Very good preparation. Okay. And as you can see over here that our patient is 12 weeks, and at 12 weeks you are getting the dual marker test. But the important point to be kept in mind is what? It's a dual marker test is only a screening test, and therefore just based on the screening test report we are not directly going to do MTP. Is this understood to all of you? No. Then what do I do? Okay, and so triple marker test and quadruple marker test are also the screening test. Okay, they are the screening test done in the second trimester. Okay, so please understand this, that when one screening test is abnormal, there is no point doing another screening test. Okay, I'll make the MCQ further tougher. Okay, I'll tell you what is the answer, but I'll make the MCQ further tough. And I want all of you to tell me the answer. Okay, so please understand this. Okay, how is the screening test report and what do you do further? Okay, so please understand this, that the dual marker test report, if the baby is having Down syndrome, if the baby is having trisomy 21, then this is the interpretation. Sir, HCG will be higher than normal, PAP-A will be lesser than normal. Okay. Okay, so please understand this, please. Yes, very good, excellent, Ruchika. Okay, so now please understand this, dual marker test is only a screening test, and dual marker report is either low risk or high risk. So if the dual marker is low risk, that is equal to normal and nothing further needs to be done. But if the dual marker test tells us that there is high risk, very good, I need to go and do the confirmatory test. Is this clear to all of you? Confirmatory test has to be done, and in the whole world the confirmatory test is the karyotyping, and that is the answer. So just on the screening test report, please don't jump to MTP. Clap if you are liking it. OG in the chat box. Are all of you understanding? Send 5 thumbs up. Okay, sir, here the always karyotyping is the confirmatory test, and therefore when the screening test is abnormal, I have to do the confirmatory test, which is the answer over here. And suppose if the confirmatory test is also abnormal, yes, if the confirmatory test, I confirm that the baby is having trisomy 21, then yes, we cannot change the chromosome, then yes, it is advisable to do the MTP or to offer MTP to the patient. It is patient's choice. Okay, now tell me this, my dear student. ये तो simple MCQ हो गया. Suppose I make it more difficult. Yes, Zinat, I'm coming to that. Yes, sir, karyotyping can be done by 2 methods. All of you. So karyotyping can be done either by chorionic villus sampling or by amniocentesis. And suppose both are in the MCQ. Both are in the MCQ. Then both are in the option. Now what is the answer? Anybody? Now what is the answer? I repeat the question. If the karyotyping is the answer over here, karyotyping is the answer because karyotyping is a confirmatory test, because the Down syndrome dual marker is showing it is positive or it is showing high risk for trisomy 21. Okay, so my dear student, please keep in mind, again a very important point all of you need to keep in mind, that chorionic villus sampling is done in the first trimester. Chorionic villus sampling is done in the first trimester, around 11 to 13 weeks. 12 to 13 weeks is what you keep in mind. It's after 10 completed weeks. So 11 to 12 to 13 weeks is when I do the chorionic villus sampling, and amniocentesis is done in the second trimester, 16 to 18 weeks of gestation. And very good, Shruti. And we are how many weeks? Sir, we are 12 weeks. So if at 12 weeks I have to do a confirmatory test, which is the confirmatory test I will have to do, chorionic villus sampling will be required. Yes or no? Clap. So karyotyping is the confirmatory test, and at 12 weeks of gestation we have to do chorionic villus sampling. Is this understood to all of you? So one level higher MCQ. If they tell you that, sir, the patient has come to, yes, very good, only after 10 completed weeks, very good, Vijay Kumar, ACOG guidelines, only after 10 completed weeks. If they tell you, suppose, if they twist the question, and if they tell you that the triple marker test is positive, or showing high risk, then what do I do? Sir, you know triple marker test is done at 16 to 18 weeks, isn't it? So if the triple marker test is high risk, then how do I do the confirmatory testing, karyotyping at 16 to 18 weeks? So then the answer is going to be amniocentesis. Yes. So clap is if you are learning the concept. So एक word important है. 11-12 weeks I have to go for CVS as karyotyping. 16-18 weeks I have to do as amniocentesis. Superb, all of you. I hope it is absolutely crystal clear to all of you. Hashtag crystal clear OG in the chat box. Is this clear to all of you? So keep this in mind. What is dual marker test? How is it done? Maternal serum, first trimester, all these lots of MCQs we have discussed, and I hope all of you are enjoying the video. And do not forget to follow me. Immediately take 2 seconds to start following me on Instagram, and please subscribe to my YouTube channel. Lots of important videos are there, and as I told you, please check out the strategy video which is already put out. Okay, last 80 days strategy video is already put out for FMGE, including complete timetable strategy is given on, and you are also going to, lots of new videos are going to come every week on the channel. Okay, now again a very important topic, tandem radiotherapy is used in. Anybody? Now what is this tandem radiotherapy and where is it used? So tandem radiotherapy, my dear student, Anybody? Yes. Now, first of all, what is a tandem and which stages? Which stages? Okay. So please understand this, that and I'll also tell you more important information. Yes. Very good. That, sir, for my cervical cancer, we have radiotherapy. Now, radiotherapy, this your radiology teacher will also tell you. Radiotherapy is a teletherapy where from far, external beam, where from far we give radiation, and we also give brachytherapy. So as a part of brachytherapy for cervical cancer, and can anybody tell me, so again the name of the topic is cervical cancer, can anybody tell me which stages of cervical cancer do we give radiotherapy? Anybody? Yeah, we are coming to that. Okay, no, you have to be very specific. Okay, Hus H, which stage? I'm coming to that. Okay, so what is tandem? First, pay attention. Another word can come, tandem and ovoid. Ovoid. What is ovoid? OVOID. Another name. Okay, tandem and ovoid. Now, what is tandem? Tandem is a rod which I insert inside the uterus. Okay, so all of you please look on the board. This is the uterus, this is the cervix, this is the vagina. So a rod in patients of cervical cancer, a thin rod is introduced inside the uterus. This is the tandem, and iske under there is a radioactive material, and there are ovoids. Ovoids are like a oval shaped instrument. So ovoid bhi answer aaya, same answer, huh? Is it clear, my dear student? Ovoid aaya to bhi same, cervical cancer is the answer. So ek hota hai rod, which is the tandem. This is the tandem, and this is the ovoid. OVOID, and this tandem and ovoid will give radiation to the patient or radiotherapy in cervical cancer. Okay, now please understand this, that along with this radiation, can anybody tell me what is another name? Do we use radiotherapy or what is added? Okay, so radiotherapy is the main treatment for which stages I'm coming to you, but nowadays we also use the word concurrent chemoradiation, and I'll tell you how the question will change, answer will change. Concurrent chemoradiation का मतलब क्या है? Concurrent chemoradiation, also called as CTRT, very important. Okay, concurrent chemoradiation और CTRT, इसमें क्या करते हैं my dear student? Yes, very good Zenith. Cisplatin is also given to the patient as a, it's not a it is a chemotherapy, but we don't directly give chemotherapy. Cisplatin is given over here as a radiosensitizer. Yes, please understand this, cisplatin is used as a radiosensitizer. One more MCQ. So see, with this one knowledge, one MCQ, so many extra MCQ you are getting. And now the most important, all of you, which stages of cervical cancer we are going to give this radiotherapy and CTRT radiotherapy, and I'll tell you how the answer will also change. Okay, so please remember this, that the stages, early stages, okay, 1A, 2, 1B and 2A, these can be operable, they are operable. Okay, beta, holy treasure, radiosensitizer matlab cisplatin when I give to the patient, it will enhance my radiotherapy. Okay, holy treasure, समझ में आ गया? It will enhance my action of radiation. Very good, Vijay Kumar Varun. Sir, stages of cervical cancer which are inoperable, stages 2B, 3 means 3A, 3B, and stage 4, 4A, 4B. These stages are inoperable, and I will have to go for radiotherapy only. Is this understood to all of you? Now, please understand this. The question came in AIMS exam, very likely to be repeated in your FMGE exam also. Now, all of you tell me the answer. So, it is radiotherapy. Now, suppose if I tell you, all of you look on the board, if I tell you cervical cancer stage 3, okay, look at the question, all of you, cervical cancer stage 3, the treatment is, okay, radical, matlab Wertheim's hysterectomy, okay, Wertheim's hysterectomy, okay, it's the name of the hysterectomy, okay, Wertheim's hysterectomy, simple hysterectomy, chemotherapy, radiotherapy. Everybody, what is the answer? Chalo, tell me in the chat box, what is the answer? These are the options. Very simple question. Stage 3 cervical cancer. What is the best management? Hysterectomy, simple hysterectomy. Very good. Very good. All of you know, sir, only chemotherapy has got no role. Radiotherapy is the answer. Okay. But now suppose if you get the question, okay, cervical cancer stage 3 and your options are Wertheim's hysterectomy. All of you tell me the answer. Chemotherapy, radiotherapy, and concurrent chemoradiation. Now what is the answer? Now what is the answer? C or D? So एक MCQ पे एक MCQ free. One more I have told you. Yes. Now the student have to keep in mind. Please all of you look on the board. Okay, sir. Wertheim's hysterectomy out. Only chemotherapy is wrong. And when CTRT, RT and CTRT. This last option is CTRT. Last option का मतलब हो गया concurrent chemoradiation. So when RT and CTRT both are in the option, now CTRT is the answer. Is this understood? That's why student tell me, sir, I'm reading the book, one time answer RT, one time CTRT. So till the time you listen from me, you can never get all these MCQs correct. Is this understood to all of you? So I repeat, sir, CTRT is better. Okay, so if your answer में CTRT दिया है, CTRT is better than only RT. Okay, so your answer will change and therefore we will go for CTRT. Is this clear to all of you? Clap if you learned something new. So here sir, RT separate hai, CTRT separate hai. Only CT is wrong. I will mark CTRT as the answer. So I give you two MCQs. Options are different, answer will change, and I hope all of you are appreciating this. And please maximum tell all your friends also to go and come and check out this video also. So tandem radiotherapy is a brachytherapy used for cervical cancer management. Short MCQ. Okay, now the next important MCQ, I want all of you to tell me the answer. Okay, 32 weeks patient. Again, I want all of you with the diagnosis first. BP of 120, BP of 180, 120, urine albumin +2, headache, blurring of vision, no convulsions are present as of now, no convulsions are present, and the best management is what? Anybody, what is the answer? What is the answer? Okay, Zenith, can you better your diagnosis? Okay, Krishna Reddy. Okay, very good. So this, my dear student, is not only preeclampsia. Why am I saying preeclampsia? Because sir, the patient blood pressure is high, pregnant lady, BP high, urine albumin +2, but it is impending eclampsia. So only preeclampsia is not the diagnosis. The better diagnosis is impending eclampsia. And can you tell me why am I saying it is impending eclampsia? Can you tell me why am I saying it is impending eclampsia? Because of the dangerous signs and symptoms. These dangerous signs and symptoms are called as premonitory symptoms. What are those premonitory symptoms? I am giving you a mnemonic OB, easy है ना, जब मैं हूं ना OGGuru है ना, OB easy है ना. That means what am I telling? O is oliguria. B is blurring of vision. Clap if you learned something new. Okay. E is your epigastric pain. H is headache. Okay. H is headache. And N is stands for your nausea and vomiting. Is this understood? Thoko tali, clap. So OB easy Hannah, okay, this one, thumbs up in the chat box. Okay, so you can see that sir, our patient in the question paper has got headache and blurring of vision. They might also mention oliguria, and therefore the diagnosis is impending eclampsia. Okay, now whenever you have a patient of impending eclampsia, what will you do? So it is not eclampsia. अब तक convulsion नहीं आया है. Okay, till now the patient has not yet got convulsion. Okay, anybody? Then why are you telling, why everybody is saying option B, C, D? Why everybody wants to give, how many want to give magnesium sulfate? We don't use phenytoin. Okay, phenytoin is not used in pregnancy. Okay, and I don't do phenytoin. Okay, now why magnesium sulfate? Now please understand this. Okay, if instead of this 32 weeks, if instead of this 32 weeks I make the question paper as 26 weeks, I make the MCQ as 28 weeks, I make the MCQ at 36 weeks, will the answer change? Like previous MCQ I showed you, if the weeks change, answer change ho gaya. Okay, yes. So please understand this, that sir, whenever we have a patient of impending eclampsia, आपने हिंदी पिक्चर में देखा होगा, डॉक्टर लेबर वार्ड के बाहर आता है और बोलता है फेमस आइकॉनिक डायलॉग, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Have you heard this dialogue before? Thankfully we don't make such dialogues, we don't make such movies now. Okay, please understand this, in obstetrics it is always mother first. हम माँ और बच्चे में से किसी एक को बचा सकते हैं. तो whom to save? Save the mother, save the baby. Indian government will say save the tiger, save the lion, save the cheetah. Doctor will say sir, save the doctor first. So anybody, whom to save? So please understand this, in obstetrics it is mother is very important, because if mother is there, she can have 10, 11, as the whole cricket team she can have afterwards. So please understand this, whether the patient is 26 weeks, 24 weeks, 26 weeks, 28 weeks, 32 weeks or 36 weeks, whatever may be the weeks of gestation, the answer will not change. Yes, and we are not giving magnesium sulfate more for neuroprotection. The answer is delivery. We have to go and do the delivery. So if the baby cannot be saved, it is okay. So in impending eclampsia, I have to do the delivery. And why delivery has to be done? Because delivery is the definitive treatment. Please write down this. Is this understood to all of you? Okay, sir, for impending eclampsia, delivery is the definitive treatment, and therefore I will never wait and watch. Is this understood to all of you? But before I deliver the patient, we will also give magnesium sulfate prophylactically to prevent convulsion. Is this understood to all of you? Magnesium sulfate is given. So only labetalol is not correct. Labetalol, yes, I have to give. Similarly, labetalol, yes, I would want to give. Magnesium sulfate also I will give, but then delivery at 37 weeks. No, jail. If you wait, we are only 32 weeks. If I wait till 37 weeks, mother will die. Is it clear? So, but to Prakash, not B. No, option B is wrong, because here option B is telling you to wait. समझ में आ रहा है? You cannot say that, sir, I will give magnesium and then I will wait and wait till 37 weeks. Never. Is this clear? Never wait and watch. Okay, so all these are the dictums. You will remember me on the day of the exam. Okay, sir, in impending eclampsia, you never wait and watch. Once you give magnesium sulfate, you are supposed to immediately proceed for delivery. And yes, we will prefer induction of labor, or then how to do the delivery, that's separate. Okay, we will induce the labor, or we may, if after inducing labor there's fetal distress or the labor is not progressing, then even LSCS may be required. But immediate delivery, and all of you write down in the brackets, the delivery has to be done irrespective of weeks of gestation. Please draw 5 stars around this word. Okay, so the delivery has to be done irrespective of weeks of gestation. So I repeat, option B is also wrong, because it is telling you to deliver at 37 weeks. The correct answer is labetalol to control the blood pressure, magnesium sulfate prophylactically to prevent convulsion, and followed immediately by induction of labor. Option C is the answer. 10 thumbs up. Is this understood to all of you? Can everybody give me a thumbs up, those who are here live, so that I understand that you have understood this? Okay. Is this clear to all of you? Crystal clear. Hashtag OG in the, okay, 10 thumbs up. Okay, is it clear? Yes, so never wait and watch. And similarly, my dear student, if it is actual eclampsia, also the same flow chart, magnesium sulfate and immediate delivery, because delivery is the definitive treatment. Is that clear to all of you? So definitive treatment is delivery. Delivery करना ही है irrespective of weeks of gestation. So very important topic, max self and all that. Next important topic, chalo, tell me the diagnosis again. So all this I have selected clinical case scenarios because those are the kind of questions now we are getting in the FMG examination, not scaring you. And one more important point, my dear student, please remember that when you are preparing for FMG, do not only FMG ka PYQs, please do last 4 to 5 years NEET PG also PYQs, which in my app I've taught you the NEET PG PYQs as well as FMG PYQs. Okay, so keep this in mind. Chalo, now we have a patient, 2 months of amenorrhea, ultrasonography, uterus is empty, right sided mass, something given to you, pulse is given to you 80 per minute, BP, hemoglobin. What is the best modality of treatment? What is the diagnosis first? What is the diagnosis first? Yes. So remember, my dear student, that patient is pregnant. How do I know patient is pregnant? Because the beta HCG is positive. Okay. And can you better your diagnosis? So please understand this, that whenever on sonography, the uterus is empty. So all of you look on the board. कि सर सपोज इफ आई डू अ सोनोग्राफी एंड यूट्रस के अंदर नथिंग इज सीन, I have to look outside the uterus. Okay, so if the uterus is empty and your beta HCG is positive, yes, I have to think of ectopic pregnancy. But all of you partly correct, partly wrong. Can you better your answer? This is it ruptured ectopic? Is it ruptured ectopic? No, sir, the patient is stable. Look at the pulse, look at the blood pressure, look at the hemoglobin, and therefore this is a unruptured ectopic pregnancy. Unruptured ectopic pregnancy. This is very important diagnosis. So please understand this. Again, never wait and watch. You'll have to go to jail. If in ectopic pregnancy you wait, how many want to mark option D? Wrong. You'll have to go to jail. Okay. Similarly, you don't repeat USG after 2 weeks. Okay, is it clear? When the diagnosis is already done, you are not supposed to wait for 2 weeks. In 2 weeks, the ectopic will rupture. Ectopic फट जाएगा. Okay. If at all there is a confusion, students tell me, sir, when to repeat and when to wait. Okay, all of you look on the board, sir. So here you are seeing this. You are seeing this right-sided adnexial mass of 2.5 by 3. So we are seeing a mass which is 2.5 by 3 centimeter ka mass. Okay, 2.5 into 3 centimeter mass is being seen outside the uterus. Is this understood to all of you? So here your diagnosis is already made. Okay, sir, one side is 2.5 centimeter, other side is 3.5. So I am seeing the mass which is the ectopic pregnancy. When do I wait? Anybody? When do I repeat the HCG? When, sir? Again PG level. Okay, sir, suppose, because there's a rule that in early intrauterine pregnancy, beta HCG doubles every 48 hours. So suppose, sir, if the beta HCG is positive and nothing is seen. So there's nothing is seen inside also, nothing is seen outside also. Okay. I repeat कि सर यूट्रस के अंदर also nothing is seen and uterus के बाहर also nothing is seen, then I would like to repeat the beta HCG after 48 hours and see whether what is the rise in this beta HCG. Is it increasing or is it how much is the increase and what? If it doubles, it's a intrauterine. If it does not double, it is ectopic. That's a separate discussion. Okay. So here, my dear student, yes, here, my dear student, the patient is stable and therefore we do not require a surgery. we are going to treat this ectopic pregnancy with methotrexate injection only. And please by heart it. Can you tell me what is the criteria? What is the criteria which I have to give for before I give methotrexate? What criteria has to be satisfied? Then only I can give methotrexate to the patient. Anybody? Anybody? So point number one, sir, whenever I want to give methotrexate, of course, it should be a unruptured ectopic pregnancy. That means the patient should be stable. Very important PYQ. Anybody size criteria? What should be the size? Yes, sir. The gestational sac should be less than 4 centimeter. Okay, and that is also matching. Look at here, अपना gestational sac कितना है? 2.5 by 3 centimeter. 2.5 by 3 centimeter. And again, please don't multiply. Okay, some students have said 2.5 by 3. Matlab, sir, 2.5, 2.5, 2.5, 7.5. No, please don't multiply this number. Okay, 2.5 by 3 ka matlab hai, sir, one side is 2.5, one side is 3. Okay, so it is still less than 4. So this means it is less than 4 centimeter. Okay, 2.5 by 3 means it is less. Okay, and very good. The fetal cardiac activity should preferably be absent, but the most important, the beta HCG levels should be less than 5,000 micro international units per ml, and that is also getting satisfied. Okay, yes, beta not 1400, 1400. Okay, so has, okay, so you can see over here beta HCG is 1500, which is good, which is matlab not very high. So here you can see, sir, we have got a unruptured patient, stable patient, gestational sac भी match हो रहा है, beta HCG भी less than 5000 है, and therefore methotrexate becomes the answer. Is this crystal clear to all of you? OG in the chat box. Okay, so the answer is methotrexate, and after giving methotrexate, we check by giving the, we have to monitor the HCG levels. HCG should be dropping down. Okay, is it clear to all of you? So unruptured ectopic, and one more thing also I will solve for all of you. Extra bonus MCQ. Tell me, how will a patient of ruptured ectopic present to us? What is very important? What is the management of ruptured ectopic? Anybody? So ये तो आपका unruptured ectopic हो गया. But suppose if you have a ruptured ectopic, what is the dictum? Okay, so the dictum which all of you need to keep in mind is shock in early pregnancy. Shock in early pregnancy. Early pregnancy matlab ke if the patient comes to us with shock in the first trimester, that means if they give you, sir, patient is 2 months pregnant, 2.5 months pregnant, and comes to us collapsed, pulse 120, BP 9. Okay, shock in early pregnancy matlab they will say pulse is 120 per minute, BP is 90 by 60. Okay, hemoglobin 6 gram percentage. Okay, and she is only 2 months pregnant. Okay, this is your ruptured ectopic. Shock in, क्या rule है? So shock in early pregnancy is ruptured ectopic pregnancy unless proven otherwise. Okay, unless proven otherwise. That means, sir, when I have a patient who comes to us with shock in early pregnancy, I have to always think of ectopic pregnancy first. Yes, very good, very good. Immediately first you need to do stabilize the patient. Okay, so what you do, to like any other shock, sir, 2 wide bore IV lines. Okay, 2 wide bore IV lines, IV fluids, you will start, collect blood for cross match. Collect blood for cross match, start the blood also, and immediately shift the patient to operation theater. And anybody, surgery, yes, laparotomy preferred, but in laparotomy what? Okay, surgery, yes, salpin, very good, Anamika. Salpingectomy, please write down. Don't feel sad that, oh, I'm cutting off patients one tube. Okay, another tube is there. Another tube is enough to cause population explosion. Matlab one tube is enough to cause population explosion. Okay, so salpingectomy, write down. Salpingectomy is the gold standard surgery for ruptured ectopic. Is this understood to all of you? Please don't feel sad that, oh, I'm cutting off patients' tube. When it is a ruptured ectopic pregnancy, the tube, it's like a bomb blast. The tube has already ruptured. There's no point saving the tube. And again, many students have a doubt. Okay, sir, I will do salpingectomy, but before that, I will push the baby inside the uterus and pregnancy will also continue. No, all that is not possible. You can't push the baby milking. Sir, हम ट्यूब को बेबी को धक्का मार के हम यूट्रस में डाल देंगे और प्रेगनेंसी भी कंटिन्यू होगा. नो, ऑल दैट इज नॉट पॉसिबल. यस, laparoscopy can be done if the patient is just early rupture or patient is stable but otherwise in shock. Remember, laparotomy is preferred. Laparotomy and salpingectomy is the gold standard surgery. So all that salpingostomy, we don't do. It is kachra dustbin. Okay, so shock in early pregnancy is ruptured ectopic unless proven otherwise. Keep this in mind. And salpingectomy is the gold standard surgery after initial stabilization. Of course, do not forget blood transfusion will also be required to save the patient's life. So 2 wide bore IV line, IV fluids, cross match and blood. So this is very, very important. If you see, my dear students, right from the beginning, what I'll just give you a quick recap. APH, the antepartum hemorrhage topic, extremely important. Cervical cancer topic, extremely important. Trisomy 21 topic, extremely important. Eclampsia, pre-eclampsia, one question for sure. And ectopic pregnancy, either ruptured or unruptured, one question for sure also. Okay, there's also the list of entire OBGY. What are the list of important topics? Also, I have said in my app also, and all of you should go through this. The last one thing, because we still have got one, please pay attention. One last important point which I would like to tell to all of you is that suppose you get a MCQ, all of you look on the board, primary amenorrhea. Anybody? If you get a MCQ of primary amenorrhea and absent uterus, this is again a short topic. Anybody? What are the only okay, what are the only 2 options? No Varun Kumar. No, Turner's wrong, Shreyas wrong. Okay, primary amenorrhea and absent uterus, very important point. All students clean bold. Please understand this, that in Turner's syndrome the uterus is present. Very important point. टर्नर सिंड्रोम में यूट्रस होता है लेकिन यूट्रस छोटू होता है, चिंटू यूट्रस. इट इज द यूट्रस इज प्रेजेंट, इट्स अ चिंटू यूट्रस. इट इज अ हाइपोप्लास्टिक यूट्रस but the uterus is present. It is underdeveloped, hypoplastic, but it is not absent uterus. Clap if you have learned something new. So please keep in mind, my dear student, in your entire gynecology, when you get a question of primary amenorrhea, absent uterus, very good, it is either your Rokitansky-Meyer-Kushner-Hauser syndrome, also called as Mullerian agenesis. And the second important point is androgen insensitivity syndrome, also called as testicular feminization syndrome. These are the only 2, not congenital. No beta, no. Congenital hyperplasia will have ambiguous genitalia. Okay, is this clear to all of you? So primary amenorrhea, absent uterus is only these 2. Clap, thoko tali, clap if you learned something new. That in the whole of gynecology, I have to keep only these 2 conditions in mind. And it's primary amenorrhea, absent uterus, or either it is RMKH or it is your androgen insensitivity, also called as testicular feminization. And how do you differentiate between both of them? Anybody? In this RMKH, the gonad present is ovaries, and here the gonad present is testes. And anybody, what is the most important karyotyping? Yes sir, Mullerian agenesis is 46XX and AFS is 46XY. ये तो लड़का है, बाद में पता लड़ गलती से मिस्टेक हो, ये तो लड़का है. Okay, till 15-16 years of age, you have read up like a girl. You will give her girl's name, girl's clothes, girl's school, but when you find out the karyotyping, अरे ये तो लड़का है. And most important, yes, very good. We are supposed to look at the axillary and not this hair, not your hair, axillary and pubic hair. Is this important in the question paper? Look at axillary and pubic hair. Okay, why? Why axillary and pubic hair you will look at? Because sir, in RM cage the androgen is normal, androgen receptors are working, and therefore axillary and pubic hair will be present. Is this understood to all of you? But in the second column it is androgen insensitivity, and therefore axillary and pubic hair will be absent. Is this understood to all of you? So now tell me the question, tell me the answer. If I tell you, okay sir, I have a patient who is having, tell me the answer, sir, I have a patient who is primary amenorrhea and the patient is having absent uterus, and if I tell you patient is having well developed axillary and pubic hair, what is your answer? Okay, and if I change one word and if I say axillary and pubic hair, okay, axillary and pubic hair, if it is absent, what is your? Yes sir, if it's well developed pubic hair, it is RMKH. If it is absent pubic hair, it is androgen insensitivity. Is this crystal clear to all of you? OG in the chat box, hashtag crystal clear. And all of you, my dear student, look at this wonderful handwritten notes. The entire notes you can revise just in 2 hours. Completely colored font, integrated images, and so easy to revise. Once you have mastered my video, all of you, my dear student, if this 1 hour of video has given you 4 to 5 MCQs, imagine when you can read the students review. Sir, my best thing was OBGY. We could clear my FMGE exam thanks to your OBGY lectures. Please understand this. Download the OGGuru app on the Android and iOS, put the ORG code YYMSTV. Get in touch with me on phone and WhatsApp on this number. And this, my dear students, only 1100 rupees. 1100 rupees, 3 months validity. So till your FMG exam is over, and totally how much? You just require 40 hours. Please understand this. It is a major subject. You are going to get 30 to 35 MCQs. OBGY is going to get you 30 to 35 marks. 30 to 35 MCQs are going to come from OBGY. So you have to spend 42 hours. Don't get hassled by 65. Everybody sees the video at 1.5 speed easily. So you just require 40 hours. My dear student, in 4 days time, students are revising in 3 to 4 days time under my guidance. You will become master and champion of OBGY, is my guarantee. You just require totally 4 days dedicate on my app, and you'll thank me on the day of the exam. I can assure you, if with your current knowledge you are getting 10, 11, 12, 13 MCQs correct, once you finish my OBGY lecture, your score will jump up to 27, 28, 29. 15 marks more, I don't need to tell you the importance. 15 marks more is a difference of score between rank of 135 and score of 150, or score of 140 and 155. So many students are stuck up at the score of 145, 146, 147. Then they take this OBGY lecture and they crack and cross 170 plus. Few years back, 42 questions had come. This includes everything. You are going to get the detailed lectures, rapid revision, MCQs, beautiful handwritten notes, of course my timetable guidance, and the mock test also. And a gift from my side, my birthday in this week, so it's my birthday and you get the benefit, and a gift from my side, 45 maximum discount what we have offered anytime to the student since the conception of the app, once in a year sale. As I said, you are going to get this master class. The name of the course is FMGE master class, and just you will get it in just 1100 rupees, 550 obs, 550 gynae, and 3 months. You are going to love it, my dear students. Every day so many students are joining and thanking me. And thank you sir, my tremendous knowledge has been boosted up in OBGY thanks to your lecture. And the way you can just see the MCQ videos in the app wherever you have studied OBGY from. Might have studied OBGY from your source, no problem. Just see my MCQ videos. They are just 16 to 18 hours. Like this, how this 1 hour video is there is 16, 18 hours. Just question, answer, question, answer, question, answer. Just even if you see my MCQ discussion videos, you're going to crack your FMG exam, is my diagnosis, is my guarantee. And please do not forget to see this video on my YouTube channel. The link is there in the description. All of you, please check out this video where what is going to be the strategy. Sir, how many exams to give? How many days to give to each subject? Please see this video. I have given the revision plan and how to boost up your GT score. This video is on my OGGuru YouTube channel. So all of you quickly check out this video. It's going to be a life-changing thing. You can have given the strategy of how to score in FMG in the remaining 80 days. Daily, day-wise schedule is given to you, as well as how many grand tests to do and what you can do to increase the grand test score. Is this crystal clear to all of you? So here's wishing you all the best. So this is my YouTube channel. Please subscribe to it. Please start following me on Insta. And the PDF, please join on Telegram. The PDF of this session is going to be available on my Telegram. I will put it immediately after the session is over. Okay, my dear students. So here's wishing you all the best for upcoming examination. Feel free to get in touch with me on phone and WhatsApp on this number. Download the OGGuru app. I once again thank Dr. Bhanu Prakash for giving me this opportunity. We will be conducting like this kind of sessions also closer to the further FMG and NEET PG examination also. And as I said, this is a 3-month. Suppose your target exam is in the month of December, January, even 6 months package is available. The students are joining me from 3rd year, 4th year onwards. So 3 months, 6 months, 12 months, 1 year, everything is available. Okay, my dear students. So here's wishing you all the best. Please check out this video. It's going to really help you in your preparation. And I wish you all the best and thank you for joining in today. Bye-bye. Best of luck. Thank you very much and see you soon.